Our final speaker for the symposium is Dr. Jeff Norman. Dr. Jeff Norman is a professor of clinical epidemiology and biostatistics at McMaster University. He received a PhD in nuclear physics from McMaster in 1971, at which point he switched fields to medical education for what he claimed were health reasons. Apparently, he was starving to death. His primary research interest in cognitive psychology applied to problems of learning and reasoning. He's won numerous awards, including the prestigious Karolinska Prize for Lifetime Achievement in Medical Education Research, which is widely regarded as the Nobel Prize of Medical Education Research. He's the author of 10 books on education, measurement, and statistics, 300 journal articles. One of Jeff's books that became popular among students of statistics was his textbook, Biostatistics, The Bare Essentials. Here's the front cover of this infamous book. Here's the back cover. I think there's not much left to cover. So please welcome Jeff Norman.
Thanks very much. Like Dan, I'm not exactly sure why I'm here. I have a niggling doubt that it might be because they could get me without paying airfare. But as it turns out, just this morning it occurred to me that there actually is a fairly good fit. Yesterday and this morning we heard a lot about how students and teachers walk around with misconceptions. Dan left us no doubt in the last half hour that educational researchers also walk around with major misconceptions. And so we have a right to, I guess, a collective smugness about how we have the inside track on truth. But in fact, what I'm going to be talking about is how we ourselves walk around with misconceptions. Now, you may not entirely agree with my point of view because basically I'm setting myself up for a kind of a David and Goliath jousting here, except that despite my physical size, I'm David and that other fellow's Goliath. Now, that other fellow's Dan Kahneman, who really did win a Nobel Prize. Yet, well, this is what they've invented tenure for, right? Okay, what I'm really taking on is research I've been doing on clinical reasoning for effectively my entire career, and I'll get to some early history in a second. But that research gives a totally different story from this very popular book that many people know of. How many people have read this book? That's all, eh? That's actually not surprising. It turns out that there seems to be a bimodal distribution there, a McDonald's distribution. People who are not in a psychology background love the book and just embrace it heart and heart. People who have a psychology background, the modal report is something like, it took me 6 months and I finally got through it, or I gave up halfway through, and because it really mattered to me, I did get to the last page. And as you'll see, my whole talk hinges on the next to last page, believe it or not. Okay. To get there, I have to begin with a little bit of early history about the astonishing life I've led. As Joe indicated, basically I left physics because I couldn't get a job at it. And there was this brand new medical school at McMaster that had invented this thing called problem-based learning. And the basic idea of problem-based learning was that if we can figure out how that basically it was a search for general problem-solving skills. And the basic idea is to try and figure out how docs solve problems so that we could teach students better. And in other words, what we're trying to find out is what are the strategies or skills that expert diagnosticians use so that we can then teach students. All seems perfectly plausible. What is implausible is they hired me to find out. I mean, this is not only implausible, it's frankly farcical. An unemployed nuclear physicist to do psychology. In hindsight, of course, they hired the wrong person, but over 40 years I've managed to mutate into more or less the right person. Anyway, we did these studies where we put docs and students in a room with people simulating a disease. We videotaped everything on black and white, reel-to-reel recorders. We went through the videotapes with people and said, why did you do this and what did you do that for? And after the dust settled, what emerged was something called the hypothetical deductive method, which was basically that expert clinicians very early on generated early diagnostic hypotheses about what might be wrong with the patient, and then gathered data by and large to confirm those hypotheses. And this is some data from way back in those days, which really says it all, which says if you got the right diagnosis as a hypothesis within the first 5 minutes, you had about a 95% chance of getting the right answer. Conversely, if you didn't, you got about a 20% chance. So this generation of early hypotheses was a very powerful predictor of what was going to happen next. The only trouble was we were looking for a process, and at one level we found a process that was too universal. That is to say, expert diagnosticians were generating hypotheses, but so were first-year medical students. On the other hand, it was not universal enough because what we found is that success on one problem was no guarantee of success on the next problem, which kind of left you to the conclusion that what really mattered was how much you knew about the domain, not what skills you brought to the domain. And that was kind of the hinge point. That led to a little speed bump, which of course I pompously call a paradigm shift. But basically, the whole research community, all 6 of us, began to think about expertise not as a skill, but as the acquisition of specific kinds of knowledge. And in point of fact, the rest of this talk hinges on 2 kinds of knowledge that experts need to get the job done. One is analytical knowledge, the stuff that they pass exams in, they spend 2 years learning before they're allowed to see a patient and so on. The other is what the concept formation people call non-analytic reasoning, which is basically experience-driven. And we've done many, many studies to show that this kind of experiential knowledge is a fairly major determinant of where the hypotheses are coming from. If you like to foreshadow what's to come, that whole idea of a hypothetical deductive method was the beginning of what might be sort of the first dual process theory about reasoning. Now, we never called it that at the time. I wasn't even aware of the idea of dual process theories until about 5 years ago. But the basic idea that seems to characterize reasonably well what's going on is that these hypotheses are generated from experience, just like the hypothesis that that's a chair is generated from experience, not from internalized rules. But then in medicine, typically, there's a long deductive phase, which is much more overt, much more formal logic. That's the idea of one kind of dual process theory. In fact, dual process theories are pretty well endemic in psychology. The people who study attention and perception talk about automatic versus controlled processes. The people who I learned with when I got back from Michigan State, the people who were studying concept formation, the Brookses and Jacobys of the world, were talking about analytical versus non-analytical reasoning, but what they're really talking about is knowledge based on experience and individual exemplars versus knowledge based on formal rules. That turned out to be a very good fit for clinical reasoning, and basically much of my career after that point, for the next 15 or 20 years, was devised to sort of find critical experimental tests of analytical versus non-analytical reasoning. Now, the focus in those was really on the nature of knowledge as being retrieved, experiential versus formal knowledge. Since that time, there's been a couple of other theories of clinical reasoning which have devolved. One is called fuzzy set theory, and it's really quite consistent with what we were talking about, that basically says that you have gist memory and you have formal memory. And these people have talked specifically with the medical diagnostic task of being gist memory as being the thing that experts bring to the situation. And it sounds an awful lot like our exemplar-based knowledge. However, neither of those are really the dominant view. The dominant view is what might be called, and has been called by St. Evans and other people, the default interventionist model, which is basically that there's 2 systems, which are called System 1, System 2, and that System 1 generates the hypotheses and System 2 essentially corrects them, that the 2 are in competition. The default mode is System 1, which is where the hypotheses come from. It's experiential, it's unconscious, it doesn't load on working memory. When System 1 fails, and System 1 fails often because of biases, cognitive biases, System 2 kicks in, it's analytical, it's logical, it's overt, it's effortful, and so on. And that basically a corollary of that whole theory is that errors derive from cognitive biases, the standard heuristics and biases that Kahneman talks about, which originate in System 1 and are corrected by System 2. Nobody says it better than Kahneman himself. Errors of intuitive judgment involve failures of both systems, System 1 which generated the error, and System 2 which failed to detect and correct it. Kahneman in turn has been adopted by a fellow named Crosscarry, a Canadian emergency doc out of Dalhousie, who also has a PhD in psychology from McMaster. And he's, if you like, if anything, more explicit. Most errors occur with System 1 and can be expected, whereas System 2 errors are infrequent and unexpected. And that's the basic dominant model in my field, and to some degree, thanks to the success of Thinking Fast and Slow, the dominant model on the street. Just to review briefly, those are the characteristics of the two systems, and we've already talked about it enough that I'm not going to bother to read them out aloud. But the fundamental idea is that System 1 causes errors and System 2 corrects errors. And that derives from Kahneman's 40-year research program about heuristics and biases. And here's where I read the book very carefully. And what I got to on page 417 of the 418 pages is that Kahneman says, well, many people have asked me, so what can you do about it? And my reaction was, you never tried? I mean, it's interesting to speculate that Kahneman's 40-year research career never once, to my knowledge, included an intervention to say, well, can we get people to be debiased? I might be wrong, but this is Kahneman saying. He says, well, I guess I'm pretty pessimistic that you can do anything, but I suppose if you ask me, one way to block errors that originate in System 1, note, errors that originate in System 1, is simple in principle. Recognize the signs you're in a cognitive minefield, slow down, and ask for reinforcement from system 2. Well, I've taken a cue from Dan, and I've used colored markers there. Because what I intend to do now is take those three phrases and say, what's the evidence? So here we go. Recognize you're in a cognitive minefield. Can doctors identify when their diagnosis is likely incorrect? This is critically important for lifelong learning and for all that sort of stuff. It'd be really nice if we could be comfortable that doctors can recognize when they make errors. Now, we've heard earlier that students can't. Are doctors any better? Secondly, if you believe the underlying default interventionist model is that difficulties originate in System 1, which is fast and unconscious. So, if that being the case, one of the things that you should find is that errors are associated with shorter times, and if we got people to slow down, the world would be a better place. Well, let's ask the first question first. Can doctors identify when they're likely to make errors? And of course, one thing we've got in this field that others don't is we have this independent variable called expertise. So the first study is a huge study, well, not a huge study, a study from 4 institutions by Friedman 20 years ago, 15 years ago, looking at final year medical students, second and third year postgraduates, and general internists. He gave them all. He had a total of 36 really nasty cases. Each subject got 12 cases. And here's what the data looked like. For the medical students, he also asked them for their confidence. Again, very similar to what I think Pooja did. And indeed, when they had high confidence, which for the medical students was only 15% of the time, yeah, they were much more likely to be correct than when they had low confidence. Interestingly, that didn't change an awful lot, except that clearly as you got more expert, your confidence went up. What was interesting also was that when you looked at the low confidence ratings, there was a really strong gradient in performance. But certainly you conclude from this overall that, yeah, it certainly looks like to some degree as you acquire expertise in medicine, you also acquire expertise in identifying when you're likely to be in the minefield. Very recently, Sandra Monteiro, who's probably here somewhere, who got her PhD last Friday, did a study where she essentially had 2 groups. One group which was told to go as fast as they can and just come up with a first impression. Another group was told to reflect on what they were doing. And I'm going to use this study design in 2 different places. The first is, so the students that are grouped who were told to go as fast as they can had a second kick at the cat. We then went back through the cases and said, would you like to reconsider? The question is, when they reconsidered, were they able to identify the errors? Well, the first observation is that although this group, this cohort, offered up 746 diagnoses in total and only had about 50% accuracy overall, they actually only corrected about 8% of the diagnoses. So their hit rate in terms of identifying errors was quite low. Furthermore, however, the students who got, this is a 2-point scale on diagnostic accuracy, the students who were completely wrong, a higher proportion of them revised the diagnoses, but some of the students who got it completely accurate, some small proportion of them also revised downwards. The second point was, well, so there is some gradient there that students to some degree are able to identify errors. Interestingly though, the ones having revised it, although they got better, this is their average score of the group who decided to revise it versus the ones who didn't, although they got better, they never achieved the accuracy of the group that did no revisions whatsoever. And in fact, what happened is there was two forces there. The group who got 0 initially went up to 0.5 on a 2-point scale. The students who were rated 1 initially basically didn't change. And the small number of students who were 2 initially, obviously they had nowhere to go but down, and that's exactly what they did. So that's the first thing, is that to some degree, there is students and physicians have the ability to identify when they're in the minefield, but it's not really very good. It's certainly not 100% accurate. The second issue is this seems so plausible as to be almost ridiculous to test. If you're in trouble, slow down and think about it. That seems like a good idea. Okay, if that's the case, then a couple of things follow from that. One is that errors are probably associated with going too fast. You're being slipshod, you're not being careful, you're not being systematic, you're not being thorough, etc. And second, by cautioning people and advising them to slow down, we should make the world a better place. Hi, Sandra. There you are. Dr. Monteiro, congratulations to you. So, an old study looking in dermatology, which happens really quickly, as you'll see. We gave 100 dermatology slides to a group of students, final year students, residents, general practitioners, and dermatologists. What we see is overall accuracy goes up enormously from 20% to the students to 95% for the dermatologists. But here's the interesting picture. When they're right, the students take 13 seconds and the dermatologists take 8 seconds. Now you know why dermatologists make so much money. When they're wrong, the students take 13 seconds, the dermatologists take 17 seconds. When they're not sure, the students take 13 seconds and the dermatologists take 28 seconds. So if you go to your doctor and the doctor says, "I'd just like to think about it," find another doctor. Unfortunately, that's dermatology, which is very visual, very pattern recognition-y. Does it still apply in more conventional mainstream disciplines like internal medicine? So very recently, we did a study where we had a group of second-year residents. These are 2 years after graduation, 75 of them, large sample size. We gave them a bunch of internal medicine cases, and one group was said, and in this group, all we said is go as fast as you can, but don't make any mistakes. If Kahneman's right, going fast, the faster you are, the more mistakes you're likely to make. Right? Is Kahneman right? Well, no, he's not. The people who were least accurate took the most, the people who were most accurate took the least time. The people who were least accurate took the most time. Now, in hindsight, that's not surprising. Accuracy is associated with knowing the answer. Taking time is associated with not being sure. It's essentially the chicken and the egg. Making a mistake is associated with taking longer time, rather than longer time leads to errors. Making a mistake is associated with longer time. Okay, but maybe that's sort of an overall picture in terms of your knowledge. What we should be doing, though, is saying to everybody, look, be careful, take your time, make sure you look at all the data. So what we did then is take a second cohort the following year, and instead of telling them to go as fast as you can without making mistakes, this time we said, slow down. And so we had a control trial where we had the rapid reasoning group from 2010 and the systematic group from 2011. Again, 20 cases and so on. Just to be very clear, the systematic instructions, be careful and thorough, don't skip anything, consider all the data, take as long as you want, consider all the data. I was so excited about this study, that finally, after about 3 months, we got all the data together, and it was a Tuesday morning in January, and I was sitting there in my outside office with the windows freezing. I got SPSS loaded up, and I got the database in, and all I needed to do was a t-test on accuracy and a t-test on time, right? And I got it all set up and went, well, there's time. The fast group was 30% faster than the slow group. And there's accuracy. 43% and 43%. God, I love large sample sizes. That's not a serendipitous one-off finding. Sandra, as part of her thesis, did a similar study using residents at 3 levels and emergency physicians. And that brings another factor in. Are the doctors, because they have more knowledge, slower and more cautious and systematic, or are they faster? Well, there's time. The emergency docs are faster than the residents. The group that's told to go fast is faster than the group that's told to go slow. But there's accuracy. Doesn't get much better null hypothesis than that. Eventually, I'll show you yet another study that involves a sample size of about 300 and some. But for the moment, what we've got is the notion that slowing down, which seems so common sense, so plausible, doesn't help at all. The people who are going fast, indeed they are faster, but there's absolutely no difference in accuracy. Okay, ask for reinforcement from system 2. If we force or encourage people to use analytical reasoning? Does that improve accuracy? Well, there's two ways that that can play out. One is what has been called cognitive forcing strategies, based on the premise that these errors are arising from cognitive biases, the Kahneman and Tversky research program, heuristics and biases. The second is, they're actually involved, they're coming from knowledge. And of course, if you take typically the studies that are done to prove one or the other, you take, in one case, 100 patients who had gone through the emergency room where an error was committed, and I think the patient died. And then they said, now, can you see any errors in this? And the answer is, oh yeah, we can find lots of errors. They don't know how many errors arise from patients who didn't die, but that's another story. But then if you say, and what cognitive biases might be happening here, then we'll find some cognitive biases. But if we say what mistakes are arising, as another study has shown that basically these mistakes appear to be from knowledge gaps. So the cognitive biases may be, in fact, a hindsight bias. But nevertheless, the dominant view is, and many, many authors have said this for 20 years, basically, errors result from rapid reasoning because it invokes cognitive biases, and the cognitive biases are what causing the error. And if we can make people aware of those cognitive biases, the errors will go away. So here's Crosscarry again talking. Alert to the influence of bias requires maintaining vigilance and mindfulness of one's own thinking. It's what we've been calling metacognition over the last 24 hours. When a bias is identified by a decision maker, you've got to decouple from system one, and so that corrective mind work can be engaged in the analytical mode. Well, what's the evidence? We did two studies, I'll only show you one, where we basically taught students two different biases. One is search satisficing, stopping before you got all the data. Typically the way you set that up is to have two lesions, a fracture of this finger and another fracture of that finger. The old admonition from the emergency room is what fracture is the most likely to be missed, and the answer is the second one. You know, if somebody has an anvil drop on their hand, they're likely to break more than one finger. But people find the first finger and stop. So that's search satisficing. The other is availability, which comes down to a common diagnosis or a rare diagnosis. So you're more likely to pick the common diagnosis and ignore the rare diagnosis. Well, so we taught one group, and then we gave them a transfer task. We didn't teach the other group. It's a no intervention control group. There's search satisficing, no difference. Here's availability. What proportion of the common group picked the intervention group picked the uncommon diagnosis? What proportion of the control group picked the uncommon diagnosis? Again, no difference. So it seems that's the only evidence there is around this prevalent view around cognitive biases. That's knowledge free. That's a general tendency, a bias. Well, maybe an alternative is to say, let's get you to really engage more forcefully with the knowledge you have. And this is a task called structured reflection. And so I'm going to show you a couple of studies around structured reflection where essentially the candidate is asked to list all the diagnoses, list all the features, fill in the blanks in terms of the relationship between diagnoses and features, and then come to a conclusion. It's based on a model of reasoning called illness scripts. So here we go. Read the case below. So two conditions. The first impression condition, very much like what we've had before. Trust your sense of familiarity, press on. And a directed search condition. Give a one-sentence summary of the case, list the diagnoses, rank the diagnoses, let's list the must-not misdiagnosis, then come to a conclusion. This approach has been popularized by a couple of friends of mine in the Netherlands, Mameed and Schmidt, and so here's one study they did involving 50 medical students and second-year residents. And there's the results. It seemed that indeed there was some evidence that it worked. For complex cases only. For simple cases, no difference. For complex cases, there's an advantage to the reflection with residents. Unfortunately, with students, exactly the opposite was the case. That in fact, with the students, the first impression did better with the complex cases, and the reflection did better with the simple cases. Now, again, there's a nice post hoc explanation for that simple is a property of the interaction rather than the main effect. But the fact of the matter is that in all of their studies, they've never been able to show a clean benefit from the reflection condition. Then along comes John Ilgen at University of Washington. 157 medical students, 97 residents and fellows, 139 faculty, 12 vignettes, 8 per subject. He didn't need a power calculation, did he? Okay. First of all, Simple cases have much higher accuracy than complicated cases. Secondly, there is some gradient in performance. The experts do slightly better than the residents, who do substantially better than the medical students. And as we saw before, that gradient is strongest with the complex cases. Thirdly, the first impression condition indeed takes a lot less time, but look at this structured reflection condition. That's 90 minutes for 12 cases. That's not too practical in the emergency room. Moreover, you have to have the whole case in front of you in order to do it. You have to go back through the case transcript and figure out what all the features were. So it's not exactly an ecologically valid intervention, but it sure is an intensive one. Well, and here's the results. Time, again, as you can see, a huge difference. Accuracy, in fact, the first impression condition is a little bit better. Perfectly timed. Thank you, Jennifer. Okay. The problem with this intervention, first of all, is that the one study, the biggest study, shows that in fact it's ineffective. But the other problem is that it's so different from the way it might be played out in the real world that it's really useful to talk about a real world intervention where we simply get people to reflect on what happened. And this is where Sandra's other study comes in. Again, a fast condition versus the opportunity to reflect. And what you saw in the initial data was that small group of people who actually did change their diagnoses. But overall, did the opportunity to come back and reflect on the condition, overall, did that make any difference? And the answer is, no. This is the fast group and the slow group after reflection. And there's another group that did the reflection from the outset. There was the fast group. Again, there's no advantage to the reflection. So, depending on what you look at, structured reflection may have a benefit, or based on the one large study, may not. But if there is a benefit, it seems to be highly contextualized and interactive. There seems to be no clear overall effective benefit, and the one big study says clearly that there is no effective benefit. Small, spontaneous reflection for the small group of people, and it's a very small group, most of the diagnostic errors went unchallenged by people reviewing it. For the small group that did reflect and change their minds, there was a small benefit, but there was a cost as well. The people who got 0 got better by 0.5 point on a 2-point scale. The people who had 2 got worse by about 1/4 point on a 2-point scale. So it seems to me that the focus on processes and cognitive biases is not a fruitful line of inquiry. Furthermore, it seems pretty obvious that simple admonitions to slow down or take your time or be careful goes nowhere. What does go anywhere? Well, there's very little evidence, unfortunately. I can't come up like everybody else has with neat prescriptions as to how teachers should do something different. We're not at that stage. But it seems that strangely, the one thing that seems to work fairly consistently is telling people to use both kinds of knowledge explicitly, saying it's okay to use both the knowledge from your experience and the analytical knowledge that you've learned from the textbooks. And there's 2 studies that show that. The first involved undergraduate psychology students learning to read ECGs. We got really good at it. After 2 hours of instruction, these students were performing at the level of medical school graduates. I have no illusions that in terms of a delayed test, they'd be back down to 0 a week later, but for the moment, they were fantastic. When they came to the test, we then said to one group, think of the first thing that comes to mind and then consider the features. In other words, do both. The second group was being explicitly objective scientists. They were given a list of all the possible features that it could arise on an ECG, check them off. Now, here's the rules. And you didn't have to memorize the rules. Now, tell me what the diagnosis is. And the first group did demonstrably better than the second group, a 20% increase in accuracy. Even the second group was doing what we thought would have been intuitively the right thing to do. List all the features, look at the rules. What was happening, as it turns out, was that by doing that, they're essentially destroying the pattern recognition part. They're now having to process the individual features. They can't weight them, they can't ignore features, and they have to explain away features that they notice which are not consistent with the actual diagnosis. Tav Ark and Kevin Eva did a second study, again with ECGs. A slight variation on it. One group was said, rule-based only, identify all the features, be a good scientist. The second group was just trust familiarity. And the third group, like our first group, was use both kinds of knowledge. And again, they showed about a 15% advantage for mobilizing 2 kinds of knowledge. as opposed to talking about processing differences. So overall, one, it's pretty evident from these and the zillion other studies that I kept hidden from you today that the diagnostic reasoning part of thing is really based on two kinds of knowledge. The experiential knowledge that doctors tell me take about 5 years after graduation until they've kind of asymptoted, and the analytical knowledge which they pass exams in from the first couple of years of medical school. It seems that it's simply wrong to suggest that all the errors are originating in the rapid non-analytic process and corrected by the analytic process. All of those studies, if one way of interpreting all those studies, that essentially the contrast is between a group which has minimal amount of explicit analytical processing and another group which has a larger, more substantive amount of analytical processing. And changing the amount of time devoted to analytical processing by even as much as a factor of 2 or so has no impact on accuracy, none. Finally, regrettably, we're not in a position to make very strong admonitions about interventions. Processing interventions, think more, go slower, don't yield anything. Interventions directed at mobilizing what knowledge you have seem to have something to do with it. Where do we go from here? Well, I think we can take a cue from all the other talks we've heard about today, which is essentially to say, let's exploit more how we can improve people's knowledge base. And so far, medicine is caught up with the idea that deliberate practice is where it's at and 10,000 hours and you too can be a consultant internist. That's a simplistic view of things. What we've heard about in the last 24 hours is it's not just hours put in, it's what you do with those hours. And diagnostic reasoning is an obvious place where something like mixed practice is going to carry the day, trying to tell apart 3 different kinds of chest pain. One's a pneumothorax, one's a pneumonia, one's a pulmonary embolus. How do I tell them apart? I mix them up and try and figure it out. And we have done studies in medicine showing dramatic effects of mixed practice. There are also studies in medicine showing dramatic effects of distributed practice. But these remain, unlike what Punja was talking about, these remain demonstration models that are done typically on the same day. It's clear that this is a field where it's absolutely natural to consider some of these science of learning interventions, but we're not quite there yet. So finally, one has to always close an academic talk. You guys did, well, yes, your whole talk was based around quotes from erudite people, so I'm going to finish that way. So here's the other Nobel Prize winner in psychology, Herb Simon. Intuition is nothing more and nothing less than recognition. We think it's intuition, but what we're really pulling back is prior experience at an unconscious level. And somehow you've chopped off my real quote. You know, if you really want to make your mark, you can do as who quoted from the, oh no, it was our lead speaker this morning talking about the Greek philosophers. Well, I don't read Greek, but I did have a really nice quote from Alfred North Whitehead from 1900 or so, who talked about operations of thought are like cavalry charges in a battle. They should be used sparingly and only at decisive moments. We shouldn't let people think too much. There you go. Thank you.